How do you complete your end-of-shift handover? Does it matter how you do it, or if we all do it the same way? An extensive body of literature identifies the centrality of clinical handover practices to patient safety, quality of care, and continuity of care. Historically, nurses have utilized a variety of unstructured methods to give report, and typically gave report in a centralized location. However, bedside handover is increasingly being advocated for a variety of reasons, of which patient safety is one of the most important and cited benefits. Patient safety in relation to bedside handover may be examined in two ways. Patient outcomes refer to the occurrence of adverse events such as falls and medication errors and are well documented in the literature as being improved through bedside handover. Patient perspectives refer to the patient's self-reported feelings of safety and have received far less attention in literature. Feeling safe is an abstract and subjective concept. I used Mullen's 4 main attributes of emotional safety to help define what feeling safe entails: trust, feeling cared for, presence, and knowledge. You may be asking yourself, why does the patient's perception of safety matter? Isn't physical safety more important? Healthcare is evolving towards an inclusive and patient-centered approach where patients are actively involved in their care and decision-making processes, and patient satisfaction is often utilized as an indicator of care quality. While many factors influence patient satisfaction, patients' perceptions of safety have a prominent role. This led to the development of my PICO research question. In inpatient medical surgical wards, does the addition of standardized bedside handover increase patients' perceptions that nurses are acting to keep them safe compared to traditional centralized handover? Synthesis of the available literature, while not of the highest methodological rigor, revealed that the addition of bedside handover allows nurses to develop Mullen's 4 main attributes of emotional safety as perceived by patients. Thus, the addition of bedside handover does increase patients' perception that nurses are acting to keep them safe. Furthermore, evidence suggested that patients' perceptions of safety are greatly impacted by the frequency of bedside handover occurrence. Despite this evidence, nurses remain hesitant to adopt bedside handover as the standard of care. I work in an acute adult general internal medicine program where bedside handover, using the standardized SBAR format, became the expectation of care in 2015, but a steady decline in the occurrence of bedside handover occurred within a few months. Subsequently, my intervention was a reintroduction of bedside handover within my unit and focused on transforming nurses' attitudes and increasing nurse buy-in into the process. The formation of a change team, comprised of a variety of staff, will aid in assessing nurse hesitations, reviewing the current process, educating staff, and ultimately reintroducing an updated process. Introducing or reintroducing bedside handover within any organization will be highly dependent on nurses' attitudes and buy-in into the process. Achieving this will be different for each organization, but using a standardized approach to handover coupled with a change management strategy may increase success. I use the 3 stages of Lewin's change theory, unfreezing, moving, and refreezing, to guide how the change team would work to educate and inform nurses of the change, as well as how to review and update the existing process within the organization. The change team needs to create an environment where the driving forces for change outweigh the restraining forces for change to successfully reintroduce and sustain the beneficial practice of bedside handover.